Dr. Hitesh? Not here. I think majority of them, everybody has put the meeting notes in now. Okay. Boss, shall we start? Or should we wait for a couple of minutes?
Couple of minutes. I'm just checking the stream.
And Maninder, what do you suggest for this obituary? We can do it on the once it is live, or we can do it later on at the end of the session.
Sorry, say that again.
I say I just wanted everybody to keep 1 minute silence for that. So should we do once the live streaming is off?
What everyone to?
Just keep 1 minute silence for his soul. So, matlab, should we do it on the last one once the live streaming is off?
Yeah. Once, yeah, I think we can do that.
Yeah,
Yeah,
once you say
we
live
stop
streaming
the
is off,
live
then only
streaming.
we'll do it.
Once we stop the live streaming.
Yeah, then only. Right. So let the session be over, then we'll think of it.
Yeah.
Shall I share my screen?
Dr. Naveen, it's almost 1 hour. Please share karo. Do you want to get it? I want to make some questions of the spine before starting the shoulder. हाँ, बहुत बढ़िया हिमालय नजर आ रहा है.
See, the streaming is a problem. थोड़ा सा stream problem कर रही है. 1 minute.
Take your own time, boss. कोई बात नहीं.
It's 3 o'clock.
The problem? Yeah, it's the problem, or should we start?
No. We are still not live on YouTube.
Good afternoon, Marinder.
Hello, sir. How are you?
Hello, hello, sir. Welcome, Dr. Sharad. How are you?
Good afternoon.
Hello, sir.
Good afternoon. How are you, sir?
Fine, wonderful. Dr. Lakhyani, आज को नया पढ़ा रहे हैं स्पाइन में? स्पाइन तो पढ़ा चुके एक बार हमें.
सर काफी कुछ रह गया था.
सर उस समय
काफी कुछ रह गया था, लड़कों को डाउट्स क्लियर नहीं हुए.
Okay.
थोड़ा पुराना रिवाइज कर लेंगे और कुछ पॉइंट्स और ऐड कर लेंगे.
That'll be great. ये तो जितना रिवाइज करो उतना अच्छा रहता है.
अरे बॉस, हम तो कहते हैं ये हर हफ्ते पढ़ा दें तो अच्छा है लड़कों को. और हाय बगीजा बॉस, वेलकम.
हेलो सर, हाउ आर यू? हेलो मनिंदर.
आज क्लिनिक पे हो? क्लिनिक पे हो, घर पे हो?
क्लिनिक पे.
पेशेंट को नहीं तो बुलाया ना? नहीं तो
नहीं,
आ जाएगा.
पेशेंट नहीं है सर. खाली बैठे हैं डॉक्टर विनीत.
ऐसे बस बोलो यार, पिछली बार पता लग गया था आप बहुत बिजी हो. आपके पास आए थे पेशेंट बीच में.
एक ही आया था बॉस, वही मेरे को पता लगा नहीं उस समय.
He came at the right moment actually, ना?
डॉक्टर शरद, गुड इवनिंग सर.
सर गुड इवनिंग. बगीजा साहब, मैं पहले सलाम कर चुका हूँ आपको.
मालिक सर, ऐसे मत बोले सर. आप हाउ आर यू?
आई एम ग्रेट, थैंक यू. अभी लाइव तो नहीं है ना मरिंदर हम लोग?
सर
नहीं सर, अभी
आई एम ट्राइंग टू सी. आप YouTube पे एक बार जाके देखेंगे सर?
मैं देखता हूँ यार बॉस, मैं देखता हूँ.
प्लीज सी. So I think we are live, sir. Yeah, we are live. So we can go ahead
Yeah, I
and
think.
start.
Yeah,
We
yeah.
can go ahead
I
and
think
start.
we are.
Please edit it.
That's
This
okay.
page. Just
Yeah,
edit.
we will edit this. Yes.
I think we are live. Not an issue.
So we always go live 5 minutes before. So whenever you join, just make sure that we are already. We start the live streaming about 5 minutes before,
Okay.
just to check.
All right.
Yeah, sure.
Acha, so shall we start with the things? With the permission of chairperson, Sharad sir?
Yes,
शुरू
sir.
करते हैं?
Please go ahead.
Yeah, Maninder boss, ready?
Yes, please. Yeah.
Yeah. Welcome everyone. I, Dr. Vineet Arora, on behalf of DOA, I welcome everyone to this 5th DOA PG class on MRI, spine and shoulder anatomy. There has been so many doubts in the previous spine MRI class, which were sought by the many of the PG students. And we were fortunate that Dr. Naveen Lakhyani is able to take up all those classes in this latest class, and he is expecting all the PG students to come out with more doubts and the questionnaires. Dr. Naveen Lakhyani, as everybody knows, is a senior radiologist consultant working with Saral Diagnostic Center, Pitampura in the North Delhi. He has been associated with DOA for quite good amount of time, and we are fortunate that he is again willing us to support extend his support for this today's session. And I welcome Dr. Sharad, Dr. Bageja, Dr. Hitesh, and everyone who as a part of DOA, and all my colleagues and the PG students. And let us try to make this session as interactive, and we can ask any number of queries. Dr. Naveen is going to speak something about normal MRI. How does the normal MRI anatomy look like in the spine as well as shoulder? And I'm sure this will give a very clear idea to all the students who are still beginning their career in the orthopedics. With these words, I will just hand over the mic to Dr. Naveen Lakhyani. And over to Dr. Naveen Lakhyani. Can you please start?
Thank you so much, Dr. Vineet. So once again, thank you so much for giving me this opportunity to share my experience with all of you. And I'm again excited to talk to all PG students. So we'll be discussing today MRI of spine and shoulder. We'll be talking about some anatomy, and then we'll see some more cases in order to understand the anatomy more deeply. So as discussed in last sessions also, whenever we see an MRI image, it is always good to start by identifying what sequence is this, and then identifying the plane, and then appreciating the anatomy, because anatomy looks beautiful on MRI. So, so we'll be revising some previous points and then going into the anatomy and some pathology. So this is a sagittal sequence of lumbosacral spine, and CSF is white in this, and we have been discussing this. Whenever CSF is white, it is a T2 weighted image. Now this is also a sagittal spine of lumbosacral region, with the CSF is black in color. So when CSF is black, we are dealing with T1 weighted sequence. So these two are very, very important basic sequences in all over the body wherever we do MRI. So first and foremost, we should identify which sequence is this. Then this is a stir sequence. Stir sequence is unique that CSF is white, but the fat is black. So all fat is suppressed in this. In this, the fat is white. This is the subcutaneous fat. This is the pelvic fat, marrow fat, which is white on both T1 and T2 WI, but it is suppressed. It is black on T1 WI on stir sequence. So once we suppress the fat, we are able to see the fluid and edema much better. So this is a stir sequence, and this sequence is also known as fluid sensitive sequence. So let us talk about something about what are the fluid sensitive sequences. So this we saw that this is a stir sequence and this is a fluid sensitive sequence. In our last session, we saw MRI of knee joint in which I shared this image. This is a PD fat sat sequence. So PD is proton density sequence, which is an intermediate sequence between T1 and T2. This also fluid is white, and we suppress fat in this when we have to do MRI knee joint, because PD sequence is very sensitive for meniscal tears. So if fat is suppressed in this, we are able to see the other pathology also, as well as meniscal tear well. This is an image of a shoulder MRI, a coronal section, and this is a T2 weighted sequence with fat suppression. So all these fat suppressed T2, PD, and stir, they are very sensitive for any fluid or any edema, and so they are also known as together as fluid sensitive sequence. So their fluid is white, fat is suppressed in all these. So we at different part of the body, like in knee joint, shoulder, ankle, we always use one or two fluid sensitive sequences, and then T1 and T2 weighted images. T1 and T2 weighted images are because of their fat planes, they're better, anatomy looks better in that, and pathology looks better on fat sat sequences. So basically their sensitivity for any edema and inflammatory pathology is very high. So with this basic information, let me show you this image. This is an axial image of shoulder. This is a T2 weighted image. We can see the muscles, the fat. There is some prominence here, but we do not know what is the pathology. This is a PD fat sat sequence in which we can see this edema very beautifully. So this is the like sensitivity of a fat, of a fluid sensitive sequence, which we do. So this just to demonstrate this importance of this edema, which is so well visualized on a PD fat sat sequence, I've shown you this image. Okay, so like now I'll be talking about anatomy of spine, but I made some slices, but I think it will be better if I go directly to my case in my monitor. So this is a sagittal sequence. We can see this is T2, stir T1. If we have to see the anatomy, I will just show you how we plan a so this is a coronal image. Coronal image is taken from anterior to posterior. This is a stir coronal image, and this runs like this. You can see in your this second column on sagittal as well as on axial that what is the planning of a coronal image. This is a sagittal image. It runs from right to left. And this is an axial image, which runs from superior to inferior. So let us see some anatomy in this coronal image. So as we go from anterior to posterior, we can appreciate both the kidneys. These are the vertebral bodies in between. This is at the level of pedicle. We can see the cord, cauda equina nerve roots. These are the pedicles. These are psoas muscles. This is part of liver, spleen. This is sacrum and both SI joints. So as we go from anterior to posterior, we can see the transverse processes. And these are the spinous processes. So Now let us see same anatomy on a SAG image. SAG image. Now on this SAG image, this green section represent the image in this second slot. So if we see this image, sagittal image, it is running along the pedicles, right pedicles. So we are able to see right-sided pedicles. These are the facet joints. These are vertebral, part of the vertebral body on right side. Then we can see neural foramen or intervertebral foramens at each level. In between, we can see the exiting nerves, the nerves coming out from the foramen. These are the posterior paraspinal musculature. As we go more inside, we can see this is the region of lateral recess. So this area is the lateral recess. So this is a sagittal image which is seen at the level of the lateral recess. As we go more in the central of the canal, we can see the cord. This cord, this section is running at this place. This is the cord, quada equina nerve roots. CSF is white in color. And so this is exactly the central image where cord is very beautifully seen. Quada equina nerve roots are visualized. These are the spinous processes of the vertebra. This is anterior longitudinal ligament, this black line. This black line is anterior longitudinal ligament. This black line is posterior longitudinal ligament. This is interspinous ligament. As we go more towards left side, we can see left lateral recess, left neural foramen, and left sided pedicles. Neural foramen, we can see the nerve coming out at each level. Axial images we take along the discs. So as we can see, this is an axial image which is taken at the level of 5, 4, 3, 2 at L1, 2 level. We can see this axial image at the level of disc. We can see the disc, both kidneys. It is at the level of the hilum of the kidney. This is the thecal sac. In between, we can see the quada equina nerve roots. These are laminae, ligamentum flavum, spinous process, paraspinal musculature on both sides. As we go down, we can see both paravertebral muscles. These are the psoas muscles, aorta, IVC, thecal sac is seen. This is ligamentum flavum. This is facet joint, spinous process, bilateral paraspinal musculature. As we go down, last time there was a point regarding the exiting, and so at each, if we go on one side of this, the nerve which is coming out here, this one is this. So at L4-5 level, the nerve which is coming out is L4. And as we will go down, this is also called as exiting nerve. And as we go down, one nerve comes out in the lateral recess on both sides. These are the lateral recesses. So these are at L4-5 level. This is an L5 nerve, and this is in the lateral recess, also known as the traversing nerve. This is the part of SI joint in the axial plane. So can you all appreciate the beautiful anatomy which we can see on MRI on all three planes, axial, coronal, and sagittal? So if anyone has any query regarding the anatomy of axial spine, of the spine, they can ask in this, because then we can go into some of some of cases in which we can further understand the anatomy and pathology.
Dr. Naveen.
Shall we go? I'll continue going.
Yeah. There was one question. If you can just, we can just
Yes,
give a
yes.
halt for this.
Uh-huh.
There's a question: how do you differentiate abscess from fluid in MRI?
Abscess from fluid
Yes.
means okay, a fluid collection from an abscess.
Yes, you are right.
Fluid
When a fluid is CSF is already a fluid over available, and an abscess now normally in case of port spinal orthopedician we are either concerned with the fracture, disc prolapse, or abscess. So the only three things are which are more concerning as an orthopedic surgeon. So would you please able to differentiate how do you make a difference between abscess and from fluid on MRI?
So like fluid will be a clear fluid will be like both will be hyper on T2 and hypo on T1, but a clear fluid will be like a fluid in the CSF exactly black in color. But if it is an altered fluid, an abscess or anything else will be not that black, will be less black than the fluid, the black color of otherwise we'll be seeing one or two cases in which I'll show you. This will not, it will not get black. It will be less black than this. And usually an abscess will have an irregular wall around it. So it will have an irregular capsule or a wall around it. And we have a diffusion weighted sequence. Usually on a diffusion weighted sequence, an abscess becomes bright and a fluid is black in color. In brain and all, we have a flare sequence. In brain and all, we have a flare sequence where also a clear fluid gets suppressed, but an altered fluid does not get suppressed. So, but in paraspinal region, if we see an abscess, I'll be showing you this. Usually, there is an slightly altered fluid, and there will be an irregular wall around it. So, I'll be showing one or two cases which will have abscess.
I think it will be more clear if you show them pictures on this one, no? So that will be great idea. And secondly, you said like on normal MRI we cannot see, but it is only on diffusion sequences we can differentiate between the abscess from the fluid. Am I right?
No, it is like this, that diffusion is an add-on sequence. We are usually able to make out the difference, but diffusion is an add-on sequence which is like sensitive for very sensitive for infarcts in the brain, and any abscess in the soft tissues becomes bright. So usually like in a doubtful cases, we can also do an diffusion weighted image, which is not a routine part of our protocol, but we do, whenever we are in doubt, we do it, and this comes bright. So there are like multiple ways, but I'll be showing you one or two cases. It is usually not a confusion. Usually when we are doing MR, usually abscess, and this is not a confusion.
Okay.
Fine, I'll show you one or two cases. While showing my cases, I'll show you.
Acha. And Dr. Naveen, can you please come closer to the mic? Your voice is slightly less audible than, clarity will be increased. That's great. Okay. And secondly, there was a question from Dr. Nasir Hussain about some about the PACS. He said how to see all sections, sagittal, coronal, axial at the same screen in PACS.
PACS means? I could get what is
idea. PACS. He has put it on chat.
PACS, picture archiving.
PACS, PACS.
So yeah, usually it is like all PACS have this this thing. Like this, I am working as a Oscillix, and it is a PAC system. So we can download any. This is a coronal. This is an axial. This is a sagittal, coronal, and axial image. We can see anything, and anywhere we can triangulate. If I want to know where exactly it is, so I can click here, and it will show me in all three planes. So these we usually triangulate for any pathology. So like all PACs, we can see all three planes. Usually imaging of MRI is done in all three planes. So this can be seen very comfortably. Any question related to anatomy of lumbar?
I think I think we can continue. We can ask some question later on because we are still.
Dr. Naveen, can I ask a clarification?
Yes, yes, sure, sir. Dr. Shah, please.
Like there are some standard sequences T1, T2. Then there are special sequences, as you say, diffusion or stir or PD. Do you, the radiologists always watch all the MRIs and then decide during the MRI which sequence to be done? Because normally I've seen the radiographer does whatever they feel like and later on you people report.
No, sir. We make a protocol. Like I make a protocol for degenerative spine, for infective spine, for spine with tumors. So we make a basic protocol, and then while the scan is going on, we observe that, and sometimes we add on a sequence or two. But usually a prefixed protocol is given to the technicians. Depending upon the diseases and all, we have further bifurcated.
Diagnosis is not clear. I mean, whether it is degenerative or is going to be infective, or you get surprises. When you're thinking of degenerative, turns out to be.
So the basic sequences are same. Like if I say T1, T2 stir, this is like standard sequences in all. So now if I have to add if there is by chance there is an epidural hematoma and I want to know, so we usually take a GRE sequence or a T1 fat set sequence. So we train our radiologists, keep training them that what add-on sequences are required. And usually we monitor our most of the cases. So it is like this that 90%, 80% of work is already planned, but 10-20% we have to monitor depending upon if any, like what we are suspecting, it comes out something different.
Is it possible later on to convert the image into the other image? Is it possible?
No. We have to call back patient.
You have to call.
If we have to do any other, it cannot change. Now we are able to get some sequences in which in one acquisition, it's a longer sequence, but we are able to get in a brain, we can get around 5-6 different T1, T2 flare and all. So they are coming, but they usually take longer time and they are still in the process in which TR and T2 can dynamically be changed.
Thank you.
Dr. Naveen, adding to Dr. Sharad's question, we just want to know, like you have just now mentioned about the PD fat suppressed images, ST star image, fat suppressed images. Do you think there's some major difference between these sequences, or it is different for different kind of part of body, like spine ke liye is ST star images, or shoulders PD fat images?
So like they have a slight different sensitivity of different things, and depending upon the part we are examining, we prefer those sequences. Like in spine, the importance is to see any small edema or any pathology. But I'm not looking for any meniscal tear or tendon tear. But if I have to see a tendon or a meniscal tear, I will preferably make it PD fat set. PD fat set will, like in this, the soft tissues are not, if you see the soft tissues are like similar. Like there's not much difference between the other soft tissues. But as we go into the PD, the other soft tissues become much more different. So their resolution and their contrast becomes more. So they become so different on different areas of the part which we are examining. There are different fluid sensitive sequence. So as an ortho, what I would suggest is that if you know that there's a fat suppressed sequence, which is a fluid suppressed sequence, and it is done in all the places with slight variation, I think that is a good information to you that you are picking up a pathology on a sequence in which fluid is white and the fat is suppressed. And you are looking for anatomy in other images in which the fat planes are well visualized.
Okay, that's great. I think we can continue because there are some questions we will take it on later on. Otherwise, there's a lot of interruption in your talk. We can continue for the rest.
What I suggest is if any query is there after any small portion of my lecture of the similar thing, we can take it, and rest of the questions we can take at the end. Otherwise, this will not get finished.
Yeah.
So
okay. Yes. Please continue. You please continue with this one.
So right. In this, I will now just show you. Just want to show one thing in this. So we all know this is a T2 weighted sagittal sequence, and we can see there's a disc herniation. So the size of the disc herniation is smaller than the neck. This is the neck, or we can say it is nearly equal to the neck. Not It is like not tearing the annular fibrous and going superiorly or much inferiorly. So this is a protrusion. Even on axial image, when an axial image come at this level, when an axial image I am seeing at this level, I can see this mark, the green line here. So we can see this as a protrusion, a bigger neck and a smaller herniation as compared to the neck. It is in the posterocentral and the right paracentral location. So we will call this as small sized posterocentral and right paracentral disc protrusion. This is at L5 S1 level. The L5 nerve has already gone out. The S1 nerve root is in the lateral recess. So we will say it is contacting the S1 nerve root in right lateral recess. So we report it like this. We report it like this. Again, I'll just say the diagnosis, what we'll give in this. We'll say small sized posterocentral, right paracentral.
Dr. Naveen, just I'm interrupting. Can you just come close to mic, because many times delegates are complaining they are not audible to them. Please.
Okay. I'll be more nearer to the mic.
Thank you very much.
Okay.
Yeah, please. Thank you very much.
So like in this, the diagnosis I will give is small sized posterocentral and right paracentral disc protrusion causing contact with right S1 nerve root in lateral recess zone. So this is the report impression you will get. Fine. So now let us see some more cases. Before that, I'll just in last lecture there was a query that when we give contrast, so indication of contrast in spine in keeping ortho as the in our mind. So usually whenever there's an infection, we give contrast to look for any discitis, any infective spondylitis, to establish an extra osseous soft tissue component. If it is there, it is better visualized on contrast. To differentiate between an epidural abscess and an inflammatory phlegmon, which has not, there's no, if the breakdown takes place, it is an abscess. If there's no breakdown, it is a phlegmon. So contrast usually help us to differentiate between these two. And for all follow-up cases of caries spine, to look for treatment response, we usually give contrast. Whenever we are uncertain in diagnosis, we give contrast for better characterization of the lesion. And in case of spinal tumors also, we give contrast. For post-op spines, we give contrast to look for post-op complications like any pseudomeningocele formation, any infection, arachnoiditis, residual disc. Contrast usually helps. Usually in cases to differentiate, even in like late post-op case also, to differentiate between a recurrent disc herniation and an epidural fibrosis or scar, contrast usually helps. So let me show you some cases.
Dr. Naveen, there is some problem with the connection.
Means?
Dr. Naveen.
Hanji.
Yeah, now it's audible. If you can close your hello, yeah, just share your screen. Yeah, that's very good. Now that's better.
I think that's fine now.
Yeah, that's better.
So shall I close my video?
Yeah, you can close your video. That will be better, I think.
Okay. So let us see this case. This patient came with pain in the neck and right upper limb pain and numbness. So this is a cervical spine MRI. We are able to see sagittal sequences in this. CSF is white, fat is also white, T2 weighted image. Fat is suppressed, CSF is white, stir sequence, a fluid sensitive sequence. and a T1 weighted sequence. CSF is black in this. I think this point is clear. If this point is not clear, anyone, please write in the chat. We will discuss it after this. Any query related to the identification of the sequence, if it is there, please write in the chat. We will clear it after this. So we are able to see three SAG sequences in this. When we go from right to left, as a convention, we always take sagittal images from right to left. So as we go from right side to left side, we can see some soft tissue in the anterior to the cord, which is causing compression of the cord. You can see it is lying just posterior to the vertebral body and causing cord compression. There is some edema in the cord on STIR sequence and T2 sequence, we can see. So axial sections of this patient was obtained. So these are T1 and T2 axial sections which were obtained. Now, if I'm going from on axial, if I'm going from superior to inferior at each disc level. So as I come to this level, this is 2, 3, 4, 5, 6. So at 5, 6 level, as I come, I can see there is some soft tissue lying here anteriorly, causing significant cord compression. So this is cord, and this is some soft tissue on T2 weighted image. You can see there is something anteriorly causing significant compression of the cord. So this is the cord, and this is the soft tissue in the anterior portion of the cervical canal causing compression. You can see the cord is showing some edema in this. As we go down, the cord is very well visualized. We can see the anterior nerve coming out, the posterior nerve rootlets are seen anteriorly, ventral and dorsal, both are very well visualized. Exiting nerves are also visualized in this. So once again, just have a look on this soft tissue which is lying anterior to the cord in the central and in the right lateral on the right side, causing significant cord compression and compressing it posteriorly. So now, like there is some soft tissue and we want to know what is the diagnosis. So this case, we gave contrast. Now here I would like to introduce one more sequence to all of you. So as all of you know, as all of you already know, what is this sequence? I really getting every time this, like I desire to ask all of you that what is this sequence, but by chance I'll not be able to hear you. Only I am speaking here in a room in this. So this is a T1 weighted sequence. The CSF is black in color. This is clear to all, and the fat is white in color. Fine. Okay, so this is a T1 weighted sequence. So here, whenever we are giving contrast, hello?
Yes, you can carry on. Yeah, we can
Yes.
hear you, Naveen.
Okay.
Yes, boss, continue. We can do.
I just had a doubt in between. Sitting in a room alone, you get a doubt that whether somebody is hearing you or not. So, okay, so this is a T1 weighted image. Whenever we give contrast, so we give in a T1 weighted sequence. A very, very important point to always remember that every time the contrast is given in body, anywhere in the body, it is given on a T1 weighted image. So because T1, you see everything is black other than fat. So what we do is, before giving contrast, we suppress its fat. So this is a sequence which is known as T1 fat SAT sequence. All contrasts are usually given in T1 fat SAT sequence. So after giving an IV contrast, we get this sequence. So in my 3 frames, we are able to see this is a T1 weighted sequence. This is a fat suppressed T1 weighted sequence. This is a fat suppressed T1 weighted sequence with contrast. So let us see the difference between this. All three. Let us see this all three images. So we can see there is some contrast in the epidural venous plexus. There is contrast in the superior sagittal sinus. There is you can see the this is pituitary. You can see the enhancing pituitary in this. So this is an image after giving contrast. So all contrast in MRI is given on a T1 fat sat sequence. And with the newer this thing, we are also able to suppress T1 from T1 fat sats. So what I can do is I can subtract this image from this and see exactly where is the contrast enhancement. So this is the only the portion which is showing some enhancement. But I'll just for a better this thing, I'll load this image again. So now if we see, this was our query, this soft tissue was our query for which we gave contrast, but we see there is no contrast enhancement by this soft tissue. Then we take an axial image also from this. We will see no significant contrast enhancement. A coronal image is also taken. This is the soft tissue, this one. There is no contrast enhancement. So no enhancement of contrast was noted in this soft tissue. This is an extruded migrated disc material which is causing cord compression. So usually an extruded disc or a recurrent disc does not enhance. Hence, there is a significance of giving contrast. No enhancement of contrast. Fine, this point is clear. Can you all hear me?
Yeah, we can hear you now, Naveen. Please continue.
Okay, fine. So, so this case demonstrates us that 2 points, 2 very important points, that we give contrast on a fat sat T1 sequence, and extruded disc material does not enhance. If it would have, if enhanced means it is an epidural phlegmon or an inflammatory pathology or a differential diagnosis of a end-plaque meningioma or a tumor. So to differentiate between these, we have given a contrast in this. So let us see one more case. So again, 3 sagittal sequences we are able to see. This is T2, CSF white. This is STIR, CSF white, fat suppressed. This is T1, CSF black in color. And we can see some altered signal intensity lesion involving the 5, 4, 3, 2, 1, L12 vertebrae, erosion of end plates, involvement of disc. And there's a like very hyper intense, very white color collection type area in the center. So now we want to know whether this osteolysis is, there's an abscess or what this lesion is. So these are the sagittal image. Axial images were obtained. So as we see the axial image, we can see that there is doubt of some soft tissues on this, some soft tissue in the paraspinal regions. There is some doubt, but we are not very sure that is there some soft tissue on both sides. So contrast was given in this patient. So again, I'll load a T1 fat set and a contrast. So this is a T1 weighted sequence. CSF is black in color. Fat is white in color. Now this is a T1 fat SAT sequence. You can see.
Hello?
Yes. You can see the CSF is black in color.
Busy against kind of pops up.
Hello, are you able to hear me?
Naveen, yes, carry on. There was some disturbance in between. Please carry on.
Okay. So like CSF is black, even fat is suppressed. So this is a T1 weighted fat SAT sequence. So we give contrast in a T1 weighted fat SAT sequence. So after this sequence, IV contrast was given, and we can see the area or the lesion, which we were seeing at L12 level, shows enhancement. There is a breakdown or a abscess formation, we'll say, within the vertebral body and disc. There's no enhancement in between. No significant epidural component. So axial sections were obtained. So this is an axial section. On axial sections, you can see that we are able to see soft tissue in the paravertebral region. Now we know that we are dealing with a lesion in which has involved two vertebrae, eroded the end plates, involved the intervening disc, and is extending into the surrounding soft tissue. We can see the enhancing soft tissue going to the psoas muscles. On a coronal image, it is also well appreciated. The soft tissue, enhancing soft tissue, is seen in the psoas muscle on left side. So this is a case of infective spondylodiscitis. Usually, most likely, tuberculosis is the cause of such appearance. So let me show you one more case, which is similar to the previous one. So this MRI was done in 2018, and this MRI was done in Feb 2018. This was done in June. So this was in June 2019. So this patient. So this is the 2018 image. This is 2019 image after one year of ADT, and we can see on T1 weighted sequence there is significant fat replacement. So this is pre-ATT, this is post-ATT. You can see the fat replacement of the vertebral body. So we can see this paravertebral abscesses in 2018, and after ATT, there are no abscesses in this. So a contrast in 2018 spine, when we gave contrast, we could appreciate paravertebral abscesses. You can see psoas abscess on left side and soft tissue on both the sides. But same patient, when came after taking ATT for 1 year, so now we can appreciate the post-contrast image of a Cox spine after 1 year of taking ATT. You can see that most of the lesion is already resolved. There were paravertebral soft tissues which are also resolved. So this patient showed a very good response to ATT, and which can be seen on a T1 weighted with fat replacement on a post-contrast image by seeing that the very minimum amount of contrast enhancement is there. This is also because of the residual fibrosis which is there. So this patient was labeled as a healed Carey spine. So, okay, we have already 7:40. So I will wind up my spine this thing. Any query from spine we can take, or contrast if there, we can take that.
Dr. Naveen, I think we can continue with the shoulder. We can collect the queries as the last question.
Fine. So let us go to shoulder. So again, let me load these three images. An axial image. So this is an axial image of shoulder. This is a sagittal image. This is a coronal image. So all three plane we obtain. These all three are T2 fat sag sequences. This is the fluid sensitive sequence which we obtained for this patient. So just see the planning. So axial images are taken from superior to inferior. This is an axial image. You can see running it from superior to inferior on a coronal image. So once we know, after taking the axial image, we take this image. This is a supraspinatus tendon. So coronal images are taken along the tendon of the supraspinatus. So this is supraspinatus tendon, black color. This is the supraspinatus muscle. So these are known as oblique coronal sequences, which are taken to look for the supraspinatus tendon and the glenohumeral joint. And similarly, the sagittal images are obtained perpendicular to the line drawn along the supraspinatus tendon. So this is a sagittal sequence. You can see running it from lateral to medial. So now we can see some anatomy in this. So I will load now coronal image. Let us see anatomy in a coronal image first. So this is a T2 weighted image. This is a fat suppressed T2 weighted image. Fine. So fat planes are very well visualized in this. So whenever we are seeing a shoulder, it is always good to first and foremost identify coracoid. So we will see bones first and then soft tissues. So this is a coracoid process. We can see this coracoid process going posteriorly. This is the glenoid. This is the glenoid bone, the scapula. This is the spine of the scapula. And this is the acromion process, acromioclavicular joint, humerus. Fine. Once again, so this is the coracoid process here, going to the glenoid bone, scapula, spine of scapula, we can see going up, and acromion. This is the acromion process, acromioclavicular joint, clavicle, mid of the joint, humerus, glenoid, glenohumeral joint. Very beautifully visualized. So now as we go from anterior to posterior, and again we go to the coracoid, the tendon which is inserted in the coracoid is short head of biceps. Just posterior to it, this muscle, which has multiple black color lines, is subscapularis, which is inserted into the lesser tuberosity of humerus. As we go posteriorly, we can immediately behind this, we'll be able to see this thing. This is a long head of biceps tendon, intra-articular portion, this one. And just posterior to it, we can see supraspinatus muscle and tendon. So going again, just going from anterior to posterior, subscapularis. As subscapularis gets finished, this black color is long head of biceps tendon, bicipital groove, It turns around like this, goes inside the joint, and is inserted on the superior portion of glenoid bone near the labrum. So just posterior to it, we can see the leading end of the supraspinatus tendon, a very sensitive area for tears. As we go posterior to this is supraspinatus. As supraspinatus gets finished, this is the spine. So this is infraspinatus muscle and tendon, and the lowermost portion is teres minor. This one is teres minor. So this we will see in all planes. The anatomy will get clear. This is deltoid, trapezium muscle. Now let us see some ligaments. So ligaments, if we have to see, it is better to see it on T2 weighted sequence because we are able to see the fat planes. So from coracoid, there is a black color structure going posteriorly. A black color structure going posteriorly. This one is coracohumeral ligament. This one is coracoacromion ligament going up. This is inferior glenohumeral ligament, also known as axillary pouch. Acromioclavicular joint. So let us see this anatomy in axial plane. So we are going from superior to inferior. This is the clavicle. This is the acromion. This is clavicle. This is acromion. Acromioclavicular joint. Just inferior to it, we can see supraspinatus muscle and tendon. It is always good to look for coracoid first. So we can see the coracoid process. We know this is the anterior. This is the posterior. So as we go down, anteriorly we can see subscapularis. So this is the scapula. This is subscapularis muscle, subscapularis tendon going and inserting into the lesser tuberosity. This is infraspinatus going into the middle facet of the greater tuberosity. And as we go down, after this, the lowermost portion is teres minor. Here, this one. This is teres minor tendon. This is infraspinatus tendon. This is supraspinatus tendon. This is subscapularis. So after identifying these muscles, this is, we can say, as the coracoid process. This is deltoid. Now let us see the anatomy on a sagittal plane going from. So this is sagittal image. This is PD fax. This is PD faxat. This is a T1 weighted sequence. So as we go from lateral to medial, we can see the rotator cuff. So this is the rotator cuff. It forms a cuff around the humeral head. So in this, it is always good to first identify the coracoid process. We know this is anterior and this is posterior. Then it is always good to identify the long head of biceps tendon. So this is the long head of biceps tendon. This goes and gets inserted at 12 o'clock in the glenoid here. So this is this one. This is the intraarticular portion of. This is the intraarticular portion of long head of biceps tendon. This one. So once we know this is the long head of biceps tendon, this we can go posteriorly. This muscle which is getting inserted anteriorly, is subscapularis on lesser tuberosity. Supraspinatus muscle, just we can follow this tendon here. Greater tuberosity, superior facet. So subscapularis, supraspinatus, infraspinatus, teres minor, posterior fibers of deltoid. As we go laterally, all these tendons join to form a cuff, subscapularis, supraspinatus, infraspinatus, teres minor, getting inserted on the greater and lesser tuberosities of the humerus. So this is the coracoid process. This is acromion, clavicle. So this is the scapula. So this is that whitish portion of the scapula where we measure the bulk of the muscle. We put a line here. If it goes above the muscle goes above the line, it is like normal bulk. If it is like touches this, we say it is grade 1 atrophy. If it is just below this, this is grade 2. And if it is much smaller with concave margin, this is grade 3. Atrophy of the muscles are graded. Similarly, there's a Gottlieb classification for fatty infiltration of these muscles. So if there is a streak of fat in this, we say grade 1. If it is slightly more than that, the fat is less than the muscle, we say grade 2. When fat and muscles are nearly equal in quantity, it is grade 3. When fat is more than the muscle fibers, it is grade 4. So we'll be seeing these cases. Fine. So in this, let me show you one or two more things. So this muscle, as we identified, this is teres minor, this is teres major, and this is the long head of triceps. So this forms the boundary of the quadrilateral triangle where axillary nerve and the posterior circumflex arteries are
It's 4 o'clock.
crossing. And axillary nerve, if it gets injured, it supplies the teres minor. So we frequently get atrophy of teres minor, isolated atrophy of teres minor due to some previous injury, which patient says. There can be, if some lesion is also there, it can also affect the axillary nerve and produces denervative changes in the teres minor muscle. So this is the anatomy in all three planes. Can you all hear me?
Dr. Naveen, yes, we can. Go ahead.
Okay, great. So this was the anatomy of shoulder joint in all three planes. We can see one or two cases. It is already 1 hour. Can I show you one or two cases? Can I go ahead?
Yeah, I think only 1 or 2 because we already 1 hour is already finished.
Okay,
You can just sum up.
Oh, okay. So I'll just show you one case, and after that we will conclude. So this is a case in which we can see this is the glenohumeral joint. This is acromion, clavicle. We can see the supraspinatus tendon is there's a complete tear of the we cannot see any tendon superior to the head of the humerus. So there is a complete tear of the supraspinatus tendon. There is superior when there is going anterior to posterior, there is a long head of biceps tendon, complete tear of the supraspinatus tendon, going posteriorly into the infraspinatus tendon. So what we do is we take sagittal sequence, and here we come from medial to lateral. As we come from medial to lateral, so we can see this is the long head of biceps tendon, this one in the bicipital groove. This is teres minor. This is infraspinatus, teres minor. So few fibers of infraspinatus are attached. So to measure this tendon tear, we go to the greater tuberosity and measure it like this. From long hair of the biceps tendon, we take a line and the residual fibers of this. So if we say it like this, there'll be around 28 millimeter of tear of superior and posterior superior rotator cuff can be measured like this. We measure the retraction of the tendon from here to the supraspinatus, from supraspinatus to the greater tuberosity, that is around 3 centimeter. And we can see there is superior translation of the head of the humerus because acromio-humeral distance is reduced. It is usually 8 to 9 mm. It is 4.8 mm. There's degenerative changes in the acromio-clavicular joint. So if we go on a sagittal T1 weighted sequence and we go posteriorly, this Y, we can see the supraspinatus is like significantly atrophied and shows fatty infiltration. Even portion of infraspinatus. So again, this is the coracoid process. This is posterior portion. So infraspinatus atrophy, teres minor, subscapularis. So we can beautifully see the atrophy of supraspinatus and infraspinatus muscle. So, okay, let me show you one last case. So this patient came to us, young patient, 40-year-old male, came with pain. He was a badminton player. So he came and there was a pain. They were suspecting superior labral tear. So this is a coronal oblique sequence. We can see supraspinatus muscle and tendon. This is the superior labrum. This one. This is inferior labrum, axillary pouch. So there was some doubt that this is a superior labral tear. Now we were not very sure. We suggested the possibility of this. So this patient came to us after 3 days for arthrography. So in this intra-articular contrast was injected from anterior approach. So in MR arthrography, we usually give diluted intra-articular contrast to distend the joint. So this so I'm going to the presentation. So this was an axial image in which we can see the joint space is filled with the diluted contrast. There is some extravasation anteriorly because anterior approach was taken. And on a coronal image, we can see this is the contrast was going into the superior labrum, this white color. Usually it should be black in color. So here there was some hyperintensity even on this. So this came out to be, this was arthroscopically operated. This is superior labral tear. So usually direct shoulder MR arthrograms are very sensitive for any small labral tear or articular surface tears. So as I could not show you some of my 1 or 2 cases in the last, so summing up will be including those points also. So fluid sensitive sequence are STIR, PD FACSAT, T2 FACSAT sequence. They are very sensitive for any small amount of edema and inflammation. Let us keep this in mind. Major indications of IV contrast in spine are infection, tumor, post-op spine, or any uncertain diagnosis. MR IV contrast is given in T1 FACSAT sequence. This herniated does not enhance. Identification of coracoid process helps in better localization of rest of the shoulder anatomy. Complete rotator cuff tears can be graded as small, less than 1 centimeter, medium 1 to 3 centimeter, large 3 to 5 centimeter, and massive more than 5 centimeter. And the measurement, as I told, is taken on a sagittal image from anterior to posterior. So this was a case of calcific tendonitis, which I wanted to show. So this patient presented with acute pain. There was a focal calcification in rotator cuff, and there was surrounding inflammation. So if such things are there, it usually favors calcific tendonitis. Direct shoulder MR arthrography is more sensitive for labral and small surface, small articular surface tears. So thank you so much for your attention.
Thank you, Dr. Naveen. Thank you very much for such a wonderful presentation. And I think that many of the things have been cleared about the normal anatomy of a spine as well as shoulder. But on the other hand, it has raised so many other doubts and questions and queries. I think I will take up some questions from the chat first, then we'll open for all the panelists. So first of all, Dr. Naveen, there was a question from one of the delegates. He wanted to know how to diagnose lumbar canal stenosis.
Okay. So as we discussed in our last session also, usually lumbar canal stenosis is a diagnosis, used to be a diagnosis of CT scan, in which we used to measure the bone margins from anterior to posterior. But over a period of time, because CT is not that frequently done and MR is more frequently done on this thing. So what we measure it, we measure thecal sac diameter from anterior to posterior. And if the thecal sac diameter is 25%, so we take 10 mm as the criteria. If it is 25% less, means it is less than 7.5, we say mild. If it is 7.5 to 5, we say moderate. And if it is less than 5, we say it is marked. Now, this is a classification of, I will say, structural for measurements. For lumbar spine, what practically usually helps us is that when there is an effacement of all the CSF around the quad equina nerve roots, we suggest that this is a significant like lumbar canal stenosis, because these patients start producing neural symptoms in the lower limbs, paresthesia and all. So there we look for CSF, when the CSF around the quad equina nerve roots get effaced, like they get completely compressed. So that we take as the something critical in cases of lumbar canal stenosis.
Okay. Secondly, I think the things must have been very clear to us how to differentiate between abscess and the fluid. So would you like to share your screen and show both the images again to that student? Okay, how the abscess looks like and what is the normal fluid?
Okay, I'll do that.
And you can share, yes.
You can see my screen is seen to everyone.
No, not at the moment.
Not in the moment, boss.
Okay.
We can see it now.
Yeah, now it's visible. Just show us two pictures. One is abscess, another one is the fluid, so that the student can have a clear idea. Okay, how does the abscess and what is the difference between the MRI presentation of? I think you had shown one slide for the port spine. There was the tubercle abscess was easily seen
I'll just show.
very clearly.
Okay. Now, this is CSF. This is white in color, like a fluid. This is an abscess, but it has a wall, irregular wall. And after giving contrast, we can see enhancement along it and irregular enhancement around these. So these are abscesses. These are abscesses. These are abscesses. And this is CSF fluid. So CSF, a clear fluid will remain white. The abscess will show slightly altered fluid. Like this is very white. This is slightly less white than this. And when we will give contrast, there'll be irregular enhancement surrounding it. So there'll be irregular enhancement of the surrounding soft tissue and an irregular wall like this. Now this is an abscess, you can see. And usually a fluid collection will has a thin wall and will not show any enhancement around it. So that is the difference. Very easily. Usually it is not if you see a case, it is usually not a concern because an abscess will be has further there's a soft tissue which shows breakdown in the center and becomes an abscess. So usually it has a good wall around it which shows enhancement.
Okay, thanks. And the next, for an infection, diagnosis of infection, which one is better sequence, T1 weighted or stir image in the spine, case of spine?
So for any inflammation, any infection, it is the stir sequence, which is more sensitive for edema and this. T1 is required. See, we correlate all these sequences and then T1 fat side is required and then we give contrast on T1 fat side. This point should be clear. So like we see T1, T2 stir, but stir is more sensitive for any edema and inflammation. And on contrast enhancement, it really picks up the contrast and puts a stamp on it that there's an inflammation with an abscess formation or inflammation with an infective process going on, enhancing soft tissue.
Okay. And there was some query related to about the healed caries. I think you showed one good slide. If you can just share that slide only once, so the doubt should be clear.
Yes, yes. Tell me what is
about the healed caries. How to diagnose a case of healed caries?
So these are the two cases. These are the same patient. On this left side, screen you can see it's MRI of 2018, and this right side is MRI of 2019. So if I'll show a stir sequence of both the time and run it together. So you can see that when in 2018, when it was diagnosed, it's a lesion which is involving both the vertebrae and quite angry looking lesion is visualized. We can see the inflammation. But with time, there is nearly resolution of most of the edema. The residual end plate erosions and all will be always seen, but you will see that there is on stir image, all the edema has gone. And even on T1 weighted image, you can see there is a lot of fat replacement.
Right. So, and then how to and this one in a healed case of that is another one. And now can we come to the shoulder? There are a few questions from the shoulder.
Yes,
how to differentiate?
Before that, sorry, can I interrupt, Vineet? There's
yes,
one
yes, Dr. Mehta, please.
on WhatsApp from one of the delegates, actually on YouTube from one of the delegates about spine, cervical spine. He wants to know whether how we can assess the canal and the foramina in the cervical spine. and the uncovertebral joints. If you can show a slide or something, or the pictures,
Yes. I'll show.
just I think
I'll show this.
clarify how to assess that.
I'll show the same image which we saw before. So this is cervical spine sagittal image, T2 weighted image. This is cervical spine axial T2, and this is axial T1. This is CSF is white, CSF is black. Okay. Now, now the query is that how to assess the. This is the cord visualized very well, and this is the canal. We can see spinous processes very well. Okay, now if I go at, okay, this is the uncinate process. This is, okay, just a minute. So when we go at a disc level, at any disc level, you can see on both sides of the disc, there is uncinate processes going up, and these ones. These are the uncinate process. Sometimes they get hypertrophic and they produce neural foraminal narrowing. So these are the neural foramen. Facet joint, neural foramen, uncinate process, disc, facet joint, neural foramen, left neural foramen, facet joint. This is the lamina, spinous process.
Thank you, boss. I think that
Does this clarifies?
Yeah. Thank you.
Yeah, I think. Yeah, that. Acha, how to differentiate between the bony and soft tissue Bankart?
Okay.
Doctor.
So this goes to one more case which I kept to show you. So this is a case of dislocation. On an axial image, now this patient had a recurrent dislocation, and this is posterior labrum, this is anterior labrum. As we go down, we can see the anterior labrum is irregular in shape, and we can see a white line going between the labrum and the vertebral body. So this is the tear of labrum from the glenoid margin. We can also see the periosteal edema going anteriorly into the glenoid, and as well as into the anterior band of inferior glenohumeral ligament. So now this is a soft tissue Bankart. But if there is a tear, there is a bony fracture of this area also along with this. So that is a bony Bankart, so soft tissue and bony Bankart. So this is seen as if we are able to see a break in this margin on a sagittal image. On a sagittal image, we will be able to see a bony Bankart as a break in this area. This is the coracoid process. This is the anterior portion. We can see a break in the anterior portion of the glenoid bone in that. So in this, we are able to see only the labrum and the periosteal edema going along the anterior glenoid margin. Here, one more good findings. Let me show you. This is the superior labrum. There is some hyperintensity in this. This is superior labral tear. And as we go posteriorly, there is a paralabral cyst. Usually paralabral cyst, if present, has a 100% association with an underlying labral tear. So we can see there's a paralabral cyst and a labral tear. This is posterior-superior portion. If I show you on this we use as the clock. Long head of the bicep tendon get inserted at 12 o'clock position. So this position is, if we triangulate, is at this position. So this is 12, 6, 3, coracoid 3, 9. So this is somewhere about 10, 11 o'clock position. We can see a paralabral cyst and tear of the labrum.
So you mean ki the soft tissue Bankard is always associated, whether it's a bony or soft tissue. Like along with the bony Bankard, the soft tissue has the labrum has to be.
Yes, either it is a soft tissue Bankard or it is a soft tissue and bony, because when the bone get break, it takes away the labrum also with it. So and we will be able to see a fracture in anterior inferior aspect of the glenoid.
Okay, that's great. What's how to assess the glenoid bone loss?
Okay, now that is there's a way to assess the glenoid bone loss. What we do is we go to this section and take the largest circle best fit circle method we use. So if we imagine that there is a fracture of the glenoid at this level, we are imagining that anterior-inferiorly there is a glenoid fracture from this line. So what we do is we take its radius of this circle, and we take the length of the bone loss. So this distance 4.6, this distance divided by this distance into 100. So this distance divided by this distance into 100 is bone loss. We take it as less than 20 is like, okay, 20 to 25 is borderline, and above 25 it is usually indicative of like the chances of multiple recurrent dislocations. So then repair has to be done. And better you will be able to say what beyond this, Dr. Sameer Mehta or you people will be able to tell me how do you deal with such cases.
We will ask Dr. Sameer also. Dr. Sameer, would you like to add something?
Yeah, I would like to add something. Hello.
Yes, yes.
Yes, you're absolutely right. We take up what we call a circle method, and that's how we calculate the bone loss. And depending on how much it is, more than 20%, then we go for what we call as various procedures like Bristows and Latargets and all that. So that's how we go about it.
Okay, that's great. Another one, another question, which is I think I got it from the WhatsApp itself, and I think it's a very basic question, Dr. Naveen.
Please.
He want to know when we are reading the sequences on the MRI from this printed MRI, which is film is being given to us, whether we are able to read the MRI is printed from posterior to anterior or anterior to posterior.
No, I couldn't get. Just repeat.
So when we are seeing the sequences on the printed film, which is being given to us. So the MRI films, which are when we are analyzing, so it has started from posterior to anterior. You said the coracoid process is the first thing to be diagnosed, to be visualized. Am I right?
Yes, yes.
So he just wanted to know.
Coronal, when we are taking oblique coronal in this shoulder, if we talk about shoulder, and we are taking oblique coronals. So this is oblique coronal. This is always from anterior to posterior. So this always goes from anterior to posterior like this. Anterior to posterior, superior to inferior, and right to left. This convention we take for nearly all places. Everywhere we take.
Dr. Vineet?
Dr. Sameer? Dr. Sameer,
well, yes, PGs are very fond of, short forms. So for those who are listening, By anterior posterior, we start with coronal sections. So anterior posterior will be the commonly we use it as CAP, CAP, which is coronal antero to posterior. And then we take axillary. When we take axillary, then we go from top to bottom. So it's ASI, right? ASI. So it's like an assistant
superior to
sub-inspector.
inferior.
Assistant sub-inspector. So it's
ah,
axillary
yeah,
superior to inferior.
to inferior. Yeah,
That's easy
great.
way to learn.
Yes, that's great. Yeah,
And
Dr.
one more
Naveen,
thing
one more.
before I'm sorry, just a question before that. Dr. Naveen, I think to measure the bone loss, we often ask for humeral subtraction CT scan
Yes.
for the glenoid actually.
Yes.
I think Dr. Sharad has also
Yeah.
just mentioned that it is actually he wanted to know whether it's MRI or the CT, but as far as I know, it's a CT scan which decides when we talk about the bone and which is taken care of the CT, which is seen better in CT, and then we do a subtraction of the humerus, and then we do put a circle method, put circles on it, and then how we get the bone loss. Am I right?
No, means it can be done on both. Yes, it is more precise on CT. It is more precise on CT, but because now for every patient, people don't get CT and MR, so we give them a whatever, maybe slightly approximate to CT scan. CT scan will definitely be more precise because of its exact bony margins. We will be not able to see that clear bony margins. So that is there. But it is still approximate, and we give in our reports if there is a significant bone loss, if there is a dislocation, patient of dislocation.
Okay.
On MRI.
Dr. Vineet, go on. Any more questions?
Yes. One more question, Dr. Naveen.
Please.
Many times the MRI report is showing about the type of AC, acromion. It has mentioned the type 1 acromion, type 2. What does that signify?
Okay. So let me go to my slides. I kept one sequence to show you all this. So these are the four types of. Are you all able to see my screen?
Yes.
Yes.
Okay. These are the four types of acromions. So it is like we take the inferior surface. If the inferior surface is flat, it is type 1. If the inferior surface is concave, this is type 2. If inferior surface there is a hooked appearance, there is a hooked type of appearance, then this is type 3. And if this is inferiorly convex, this is type 4. So usually type 3 and type 4 are more prone for rotator cuff impingements and injuries, but type 2 is the commonest which we see in our reporting. That is the commonest appearance we see.
So does it have any significance that having type 2 will have the less chances of having the impingement syndrome?
Yes, definitely, because this will have a less chances of impingement. This and this has more chances of impingement.
Okay, great. So I think the next question is related to this also. How do you diagnose the impingement syndrome on MRI?
So impingement is a clinical diagnosis.
It's a clinical diagnosis. This should be very clear.
It's clinical,
Yes, and MRI only helps us to know the pathology inside. If anything, like the hooked acromion, if that is causing the pathology. But even without acromion pathology, you can still have an impingement by any inflammatory pathology of the bursa, etc.
Yeah, so then we go for the subacromial decompression and all that. Huh? I think that is the one.
Yes, whatever, injections or whatever you want to do.
So like
yes, you're right.
Impingement, one, it is a clinical diagnosis. Second, it's a dynamic process. So as an MR reporting, we never write as an impingement. We give all the findings, tell us reduce space, this and all. And once it is clinically correlated, then we are able to say that what impingement is there. So as Dr. Sami,
right, correct.
Right. So I think that most of things have been solved. The questions which have been asked. I think there was one more question. What is Maverick sequence?
Maverick.
Dr. Naveen? Yes, Maverick sequence.
So Maverick sequence is a special sequence to reduce the metallic artifacts. So as in the last session also we discussed, and now with slightly longer sequences we have, in which we are able to reduce the any metallic artifacts around any lesion. So that is a Maverick sequence. If I might be able to show you one image.
In the meanwhile, there's a question which I think Dr. Sameer can answer. How do you, on many times on the MRI, the AC joint is abnormal. How do you decide whether this is not the site of pain or is it something else?
Yeah. Well, the answer to this is very simple. If you, there is a very typical for diagnosis. See, MRI comes much later. It is a clear history that patient talks of pain. Then there is something called as point tenderness. I don't know. My panelists might be able to. There's a point tenderness at AC joint. It's a point tenderness. One. Secondly, if you do a cross reduction test, there is a typical test that you clinically do, and then which typically it increases the pain on that AC joint, along with that point tenderness. So by this, you already have a kind of diagnosis that it's an AC joint. And furthermore, the MRI will help us, and the radiologist here comes in the picture. He'll talk about the inflammation or an arthritic features in the AC joint, which whether it's a synovial, after all, it's a synovial joint, whether he talks of erosions there or called a synovitis. So comparing both the two, then you know that this is a typical AC joint arthritis causing pain. And then you further go ahead, whether you go for minimally invasive of doing any ultrasonic treatments or painkillers, and going further to give injections, and then further you do arthroscopic procedures and like Mumford procedure, etc., where you deal with it along with other, if there are any other pathologies.
Okay, that's great, Sameer. I think is Mars and Maverick sequence are the same, Dr. Naveen?
What?
Is the Mars, M-A-R-S, Mars sequence or Maverick sequence are the same?
No. Maverick and CMAC. There are two sequences. Maverick is in G and CMAC is in Siemens. So these two sequences and different vendors are similar sequence, which are special sequences to reduce the susceptibility artifacts, the metallic artifacts which are produced in an MR images.
Okay, are you able to show some slides for the Maverick image? You're just trying.
I don't know why the images are not getting opened up.
Okay.
This time.
Okay.
So Vinny?
So yes, sir, please. Yes, sir, please.
Dr. Lakhyani, many of our patients are claustrophobic. If they refuse to go inside the machine for MRI, then comes the concept of an open MRI. So I want to know, what are they? Are they really effective for a patient of claustrophobic? And third, are their resolutions and results are as good as the standard MRI are?
Okay, sir. Open MRIs were previously we used to have open MRIs in which they were used to be 0.3 or 0.5 Tesla strength, and the now in the 1.5 and 3 Tesla we have a tunnel kind of an appearance, and there's a current going in the tunnel, around the tunnel, which produces the magnet with the electric current, and there will be large magnets, superior and inferior, and there used to be an open area in between. So that is nearly now not seen, and they used to be 0.3 and 0.5 Tesla, which is very low resolution images. It used to take a lot of time. So now nobody is making this. Like in Delhi, we will not have more than 2, 3, 4 old these open MRIs have very low resolution and takes a lot of time, and it's usually not of much use to get it done. Better is to what we do is we have an in-house, or usually all MR centers have an in-house anesthetist which mildly sedates the patients, and we get an MR done. We try to explain to the patient. 50% of patient they get it done, and those who cannot get it done, they get it done with mild sedations.
These tunnel MRIs, are they available, and are they able to reduce the fear of the patient? The tunnel MRIs which you say available now.
This open MRs.
And the tunnel ones which you're saying.
Tunnel to sir ab hai 1.5 and 3. What we are using are tunnels.
Okay. Are they able to reduce the fear of the patient?
No. I'm saying, sir, these tunnels, they produce claustrophobia in patients, and so they are that is what is used. Open जो है वो tunnel की तरह नहीं होता. There are two types, open and tunnel. So tunnel, there is a claustrophobia. Open, there is no claustrophobia, much less claustrophobia, but usually the resolution is very low.
Okay.
Because it is 0.3 or 0.5 Tesla. You cannot make a higher Tesla MR and keep it open. You have to close it.
So it's better to go with sedation rather than go for the other.
Yes. There's no point getting an MR done. Like in my previous years, in about 15-20 years back, I have worked on open MRs, but the resolution and time taken is more, resolution is very low. So better is to go for these higher Tesla images.
Dr. Naveen, Dr. Sharad asked a very pertinent question. Nowadays, even patients want that. They come and ask us, कि sir, कहाँ कराऊं जहाँ पे open हो? मुझे बहुत डर लगता है. So this is a very valid thing. I think in future, future this would be
Yes, sir.
manufactured by the companies, I guess.
Yes. There is work going on in which they are increasing by using AI, deep learning, and all. They are increasing its capacity of an open MR to bring out. So, but still, this is I just talked to some of the vendors and all, but still, it is openly. We are not able to. Till now, we haven't got any new open system which is good in resolution.
Okay, Dr. Naveen, I have a question.
Please.
Dr. Vineet, can I ask?
Please, sir.
Yeah,
Please.
sure.
Okay.
After that, Dr. Bageja will ask. He is already on the queue. Yes,
Okay.
please.
See, there is something called as, Dr. Naveen, there is something called a grid pattern in a shoulder MRI. Grid. Now, what is that? Because I've been told that MRIs which have a grid pattern are the right ways how cuts are taken. Some of the MRIs from some of the centers do not have a grid pattern, and they do not actually show the images as well. Now, what is this grid pattern, and should we be really concerned about it? कि सरल से grid pattern आता है और इससे नहीं आता हमें.
No, sir. I haven't heard anything of this, sir.
Okay. Maybe I'll learn it, and then maybe I'll share it with you what a grid pattern is in some other.
Please kindly ask my question to Dr. Naveen.
You will read you by yourself, Dr. Bageja, please. Meanwhile, Dr. Benji, welcome. We are seeing you after a long time.
Dr. Naveen, can you hear me, please?
No, sir. Please, Dr. Bageja.
Dr. Naveen, can you hear me?
Yes, sir. I am able to hear you.
This question to whole faculty, basically. Can you hear me?
Yes, sir. Please.
Yes, we can. Please go ahead.
I've got one patient, fracture nailing, heel fracture nailing. It is not linked to this talk. It is a general question.
Please.
And 7 years post heel fracture tibia, right? Patients coming to me with a pain in the leg. On examination, there are no sign of infection, no tenderness, no redness, nothing. But ESR CRP is very high. So what is the modality of treatment to confirm is there any infection around the nail, like CT, MR, or bone scan, and how to go about, Dr. Sharad? Any comment from your side also?
Yes, Dr. Sharad, can you answer?
7 years post-op?
Yes, sir. Heel fracture, sir.
And intermedullary nailing has been done?
Yes, sir. Tibia nailing, yes, sir.
And patient just have pain now and no other feature. You're not finding any local. What about local tenderness or thing?
Nothing, sir.
And just pain in the leg, right?
Pain in the leg, ESR CRP high.
Well, ESR and CRP becomes bit non-specific when you are not having any local features. And in my clinical practice, and I'm sure others also, we do get pain because of the implant at some stage, which is not definable. We're not able to define the reason, and would suggest to go and remove the implant. And
so I'm planning for removal, but I just want to have one test, one investigational choice. Dr. Naveen can help us to know to.
I think that test could be. I think WBC labeled scans are there, which able to pick up infection.
Bilkul, sir. WBC labeled bone scans are very specific to pick up any infection. So they are usually done in such cases.
All right. Thank
But
you.
But
for that,
Dr. Bageja, if you don't get that infection, then tell the patient that the pain can be because some other reason. I may not go after the implant anymore.
Right. Thank you, Dr. Vineet. Thank you. Dr. Sharad was saying last comment. Dr. Sharad was saying something.
yeah, I was saying that in any case, even if you prove that there is an infection, we'll remove the implant. The treatment choice would be to remove the implant. So
Right, sir.
you
Yes,
might
sir.
as well as remove the implant, take cultures, and
Dr. Dhananjay, would you like to add
it will go away.
Right, sir. Thank you, Dr. Sharad. Thank you.
something?
You'll have to unmute yourself, Dr. Dhananjay. Yeah.
I think the clinical presentation is definitely most important, because if I find there is pain, tenderness, swelling in that area locally, patient is having difficulty in weight bearing, and in that scenario, if the ESR CRP comes high, then definitely yes, it is infection for me. And we should look for other evidence in the plain X-ray also. Even the CT scan is going to be helpful, and whether it's a delayed union or
There's
infection,
some
something
network issue
The
on
union is there. Healing is
the
done.
side.
Healing is done, sir. Infection, I'm looking forward, basically.
And there are no local symptoms. As per Dr. Bageja, there is no local features.
No, sir. Only pain leg. That's it.
No tenderness, no swelling.
No swelling.
so let's not treat the raised ESR and
Is
Yeah,
it
yeah.
available?
Yes.
So that's why before removal of nail, I just want one confirmatory diagnosis to look for it. That is all.
Only thing, WBC scan is not done everywhere. You have to search where to get it done.
It happened in Gangaram, I believe, sir.
And
Happened
then
in Gangaram.
last time I sent a patient there, it was not being done at Gangaram also at that time. Ultimately, you got it done in Max Saket. Dye का चक्कर रहता है. I mean, they're not able to prepare the dye in time.
Yes, sir. Yes, sir. Dr. Naveen, any comment regarding CT or MR? Any help in that, or we have to go for bone scan only?
For the this tibia, in the same case you are saying,
Nail inside, yeah.
nail inside. If there is no tenderness,
Hello.
if there is no hello, are
Yes,
you able to
sir.
hear me?
Yes, yes.
Yeah, Dr. Sharad.
Yes.
Dr. Sharad,
Yeah.
can you have the last word
Dr.
before we
Lakhyani.
finish off this meeting?
Dr. Naveen is commenting something. We need 1 second. He's saying something.
Hello. Yes, yes, sir. If there is no tenderness,
Dr. Sharad.
So we need Dr. Lakhyani is giving his views.
Dr. Sharad.
He's not able to listen. Can you hear me? Dr. Maninder, can you hear me?
Yeah, we can hear you. Dr. Sharad, we can hear you. Yeah. So Lakhyani, Dr. Lakhyani, I think you can carry on and finish that, and then we'll finish with final words from Dr. Sharad.
Dr. Bageja, there is if there is no tenderness, no swelling, then usually MR or CT will not add. X-ray is good. Beyond X-ray, it will not add anything much.
Okay. Thank you. Thank you.
Well, then on behalf of DOA, my sincere thanks to the master of ceremony, Dr. Naveen Lakhyani.
Thank you, sir. Thank you.
Comments of one of the participants, I think, echo the sentiments of all of us. He has written that today, after MRI of shoulder, for the first time in my life, I've understood the anatomy of shoulder in MRI.
Oh, thank you.
I
Great.
think all of us feel the same way. And sincere thanks to the host, Dr. Vineet, Dr. Marinder, Dr. Rehan, and our EC members, panel, and especially all participants who are so enthusiastically